This is what we hope will be the first of many trust-related conversations as part of the Foundation initiative. And what we're really trying to do is elevate the importance of thinking about trust as an independent strategic goal that organizations can focus on to try to be successful as they are healthcare organizations. And one of our operating hypotheses is that many people in scientific medicine assume that the patients trust us because everything we do comes from science, and we have the New England Journal of Medicine to prove that what we say is true. And we think that in the way the world is moving now, there are deeper questions that patients bring when they encounter medicine in any form, and that trust is a key ingredient to being successful in healthcare. Dhruv, I want to thank you for finding the time to be with us today. You've been writing a lot about the pandemic. You've written some of the clearest. I've shared your work in the New Yorker with many colleagues and family members to say, if you want to understand how we think about getting COVID under control, here's a clear explanation of the science. Here's a clear explanation. You've been wonderful that way. And you obviously share an interest in trust. What do you think are some of the most dramatic learnings from the pandemic relating to trust in healthcare?
Yeah, Rich, first of all, thank you so much for having me. I was really excited to be asked to join for this conversation. I think, obviously ABIM has been thinking about trust for a few years, and the broader medical community has as well. The first thing I would say is that, the pandemic has really just spotlighted the importance of trust and mistrust in the healthcare system, in the public health community. So literally everything that we needed to do during the pandemic, whether it was communicate effectively, whether it was getting people to adhere to mask wearing or capacity restrictions, social distancing. Now we see it with vaccine uptake, letting people know that it's safe to re-enter healthcare settings, that we have the right safety protocols in place. All these things are underpinned by trust. And so, I know we have some time and we'll dive into kind of each of these elements, but I think at a broad level, what the pandemic has really revealed is that trust is central to everything that we do. And it's also exposed a lot of the kind of inequities and the fractures and the issues that we have within the healthcare system, some of which result from trust and some of which I think could really benefit from a dedicated kind of initiative like the one that ABIM and others are focused on to try to rebuild trust.
Well, thanks for that reflection. And going a little deeper in a couple of the things you said, you described the pandemic as putting a spotlight on the healthcare delivery system in a way that revealed some deficits and fissures that particularly created some trust issues. Can you say more about that? What were the things that the spotlight illuminated that were most notable from your point of view?
Yeah, I would point to a couple of different examples. I think one big thing that comes to mind, particularly for clinicians who are caring for patients early in the pandemic and throughout the pandemic, is trust between clinicians and their healthcare organizations. And I think at a broad level, it's interesting to think about whether that has increased or decreased. It seems like there may have been a small decrease. You can talk about the survey that ABIM did, but I think there's tremendous variation across the country. And so, my trust in my organization, for instance, increased during the early months of the pandemic. We had kind of clear communication from healthcare leaders. We knew that they were working to get us PPE that we needed to stay safe. We had a good sense of the numbers of patients that would be coming in. We had a plan in place to increase our ICU capacity. And so, whatever my level of trust was before, it was higher afterwards, because I thought in a moment of crisis, I was really impressed and heartened by the response that came from our healthcare leaders, as well as the camaraderie that came from working with other physicians, nurses, other healthcare workers to kind of combat this problem. I think that experience was very, very different for a lot of clinicians across the country. So many clinicians didn't have PPE, they didn't have clear communication, they didn't have the support of their healthcare leaders, and you can understand how that would really decrease the level of trust that they have in their organizations, and what a problem that will be during the pandemic, but also going forward. So I think that is one example. There's obviously many other examples that relate to patient trust, and so I think about in this domain, particularly things around vaccine hesitancy and whether patients feel comfortable talking to their doctors, talking to their nurses about getting the vaccine, where do they want the information to come from, whether they'll believe what they're being told by their healthcare providers, whether they'll believe what they're reading on the news or on social media. And so I think that's a really important and kind of tricky space to navigate, but one that's incredibly important.
Right. Let's stay for a minute with physicians and their institutions, because you're right. Our survey did show that that physicians had less trust in administrative leadership in their institutions than they did, for instance, in their colleagues, and the closer their colleagues were to them, the more trust they had. But I want to ask you, when you say your trust in your institution increased, so you're in a well-resourced, high-profile institution, but you were at ground zero of the epicenter of where COVID hit. And so early on, you say they told you, we're doing what we can to get you PPE. I'm hearing in that there were periods where you didn't have all the things you needed to take care of patients. So I think there are maybe some lessons there worth expanding on. There were situations that your healthcare system faced during the pandemic when they couldn't do what they wanted to do, when they couldn't do what you wanted them to do, and yet you still feel that your trust in the institution went up. What's the secret sauce? What do leaders need to do when they don't have all the things they'd love to have to try to do the right thing?
No, it's a great question. It's a great point. Look, the pandemic was in some ways, it took everyone by surprise. There were kind of severe capacity constraints. There were supply chains that were disrupted. There was a lot that was out of the control of everyone, particularly early on. And, we've talked about the kind of crucial elements of trust. And in my mind, there's three crucial elements. And if you're a healthcare leader, or if you're anyone, and you can deliver on these three elements, I think you can do a lot to improve the trust in your organization or with other people that you're serving or interacting with. So the first is competency. And so being able to demonstrate that you know what you're doing, being able to answer that question for people, do you know what you're doing? And I think, whether or not you're able to ultimately do every single thing that you had promised or tried to do, if you give off the impression that you're competent, that you're effective, I think that's the number one thing. Number two is then transparency. And so not only do you know what you're doing, but will you tell me what you're doing? So, will you let me see potentially some of the challenges that you're facing, why it is that it's so difficult to do the types of things that we need to be doing right now? That can go a long way to helping people understand, we're trying our best to do this. We're good at doing it, but there are some limitations that we're facing, and that's why it's not happening as quickly as we want it to do. And the third is motive. And so the first is competency. Do you know what you're doing? The second is transparency. Will you tell me what you're doing? And the motive really comes to, are you doing it for me, or are you doing it for yourself? And so demonstrating that the things that you're doing are not necessarily in your own self-interest, but in the interest of the people that you're serving, whether that is the healthcare workers that you're working with, or whether that's patients that you're serving, whether that's other stakeholders. And so if you can answer those three questions in kind of an encouraging way, even if the end result isn't exactly where you need it to be or wanted it to be, I think you can still demonstrate trustworthiness, which I think is the first step towards, gaining trust. But Rich, I'd love to hear kind of your perspective on that and some of the learnings from the survey that you all did, and what you've been hearing from other members in the organization.
Yeah, well, I think, Your observation that it isn't just about resources and it isn't just about success, that sometimes in healthcare we're going to be confronting situations that exceed our capacity, and that's going to be true with physicians dealing with desperately ill patients who may not survive, and trying to explain that to families. It's going to be true with administrators trying to explain to a clinical staff, we don't have sufficient access to chemicals to do testing at the volume we'd like to do, or to turn around testing at the volume you'd like it done. I think it's really important to stress that when you talked about three things that build trust, it wasn't about money, it wasn't about resources, it was about qualities of leadership, transparency, competence. These things are critical for, and they're available to anybody in the delivery system. So I think our findings did show that that there was a degradation of trust, and that the closer you were to, I'll call it personal relationships, the stronger that trust was. So doctors trusted the doctors in their own practices more than they trusted doctors in other practices, more than they trusted healthcare administrators. And I think there's a pretty important learning there, because when the team that assembles itself around patients to meet their needs does that, the lack of trust that one portion of that team may have in another portion of that team is not something that inspires patient trust or patient confidence. And there's nothing like the doctors complaining about the other doctors or the administrators to undermine patient trust. And I think it's, you're pointing to the qualities of leadership that make a difference. I think that's really powerful.
Yeah, one of the things that you brought up that I think is really I've been thinking about, and I've been trying to get my head around it. So I'd love to hear your thoughts and potentially the audiences. But the challenges of kind of scaling trust. We hear so much that trust is about interpersonal relationships, and a relationship with your primary care doctor, having a pre-existing kind of relationship with someone who can walk you through a challenging decision. We see survey data from Kaiser and others that, still, even in this day and age, the number one kind of person that patients or the public want to go to learn more about vaccines is their doctor or their nurse. That's who they want to understand these issues from, not online, not from social media and so on. And really engaging in that authentic dialogue is incredibly important. But it also strikes me that it's something hard to do at scale. I mean, you could say that everyone should have kind of a relationship with a primary care doctor, should have a relationship with someone. But in this day and age of technology and wanting to do things quickly and rapidly and figure out how to deploy something across millions and millions of people, that type of interpersonal relationship can be hard to kind of just replicate over and over again. It takes time and effort. So, how do you think about that as, an organization that's trying to promote trust in medicine in America, recognizing that there's not an app that's going to do that, right? That it's going to be much more challenging than that.
That's a terrific question. And I think that it begins with the idea that we can't overly romanticize the individual physician-patient relationship as the foundation of everything. That, as Daniel said, I practice primary care in the community where I live for 30 years. I noticed that a lot of my academic colleagues, they would say to their, and my patients were friends and colleagues, and my wife's colleagues and my kids' teachers. It was very high stakes and personal. And I noticed that some of my academic colleagues would say, well, if you need to reach me, don't call the office because it's just terrible when you call the office. Let me give you my cell phone, which they would do for their friends or VIP patients. It was clear to me that since everybody who was calling was going to be a VIP, I needed to focus on building a reliable system. And I spent a fair amount of time not in the practice physically because I had administrative leadership roles while I was practicing. So the promise wasn't, when you get sick, I'll be there. The promise
Mhm.
was when you get sick, you'll get what you need. And
Mhm.
you needed to think about that from a patient point of view. And I think those are lessons that are applicable to systems more broadly. What are the things that destroy trust? What are the things that build trust? So one of the examples I love to talk about is my colleague Chuck Kylo, who tricked out his electronic health record to demonstrate a phonetic pronunciation of a difficult to pronounce patient's name on the home screen, so that
Mhm.
all of the team taking care of that patient would pronounce the name correctly. We think a lot about how to use technology in systems, but how many of us are thinking about, oh, could we use technology to empower everyone who has contact with the patient to build trust with that patient from word one? So I
Mhm.
think I think the lessons, your scale problem is exactly right. If we start with a naive sense that the only way trust happens is between individuals, we miss all kinds of opportunities to build trust at scale as a system property. And one more comment on this, I think there is now something all of us are familiar with, which is a kind of distributed trust, distributed trust as a concept. Um, if you get into an Uber, who or what exactly are you trusting? Is it the driver? Is it the app? It probably isn't Travis Kalanick or whatever his name
Mhm.
is. You're trusting something that's been created to meet a need you have, and it repeatedly, reliably, comfortably meets that need, and that's how trust can be built. And I think we have a lot to learn. Oh boy, if the information technology industry gets anything, it gets scale. I think we have a lot to learn from them in healthcare.
Mhm. Absolutely. One of the things
Pivoting to,
that, go ahead, please.
no, I was going to say, pivoting a little bit to patient trust issues. Obviously, one of the things out there that you and I had talked about before, vaccines, and where we seem to have hit this plateau on vaccine. Uh, what are you thinking about that? How do you think? And clearly, a lot of that seems to be based on trust. How do you think? How do you think that we can cross that trust chasm with so many people around vaccines?
Yeah. I think that's probably, the fundamental question for the next few months and year at least. And it's such an important topic, particularly, we see new variants arising. It feels like every day. I've been thinking a lot about the Delta variant, which is kind of vastly more contagious and potentially more pathogenic. But as far as we know, still, subdued by vaccination, and that really is the best treatment that we have for this ongoing problem. And I used to think, people could be vaccine hesitant only because they hadn't lived with the consequences of a terrible disease. So polio was in the past, and smallpox was in the past, and so people could they didn't directly feel that. And that clearly is not the case. We've all gone through an unprecedented crisis for the past year. And so it's not that people don't believe that these things can happen. It really is an issue of trust in a lot of ways. And so, um, there's a few things that I've been thinking about in this space. I think the first thing to think about is not letting vaccine hesitancy be an excuse for low vaccination rates. And so I think before we go down that path of saying, people are vaccine hesitant, that's why we have high numbers of unvaccinated people, we need to make sure that we've done everything to create access, and we've made it easy, whether through giving people time off work, or incentivizing people, or making sure that they have the ability to get vaccinated at a local site or through their primary care doctor. That needs to be the very first thing that we need to make sure. I think, beyond that, there's obviously a tremendous amount of education that needs to happen around it, and continuing to drive home the message that vaccines are, the most life-saving, remedy that we have. I do think it's important to try to avoid making hesitancy part of one's identity. And so often in the media, often, all of us, we talk about these communities are ones with low vaccination rates or high vaccine hesitancy. This political party is the one where they don't, really take up vaccines. And that might actually empirically be true. But once you start to tie levels of vaccine hesitancy to one's identity, it becomes very, very hard to change people's mind. And so I think we need to be very careful about the way that we label people, and the way that we make them feel like, me taking the vaccine or not taking the vaccine is part of kind of who I am. Beyond that, I think it's things that people have been talking about a lot. I think community outreach, making sure that you use kind of the messengers within that community that have high levels of trust. Sometimes that's faith leaders, sometimes that's educational leaders, sometimes that's an elected official, but really doing kind of a local deep dive into who are the types of people within this community that are going to help us. And then the last thing, I will say is this idea of an unlikely messenger. And I think that's something that we've talked about before too. And so when you can find someone who is speaking kind of against their self-interest and telling you to get vaccinated, that can be powerful. So if you're from a political coalition that typically has higher levels of vaccine hesitancy, but you're a leader in that community and you say, you know what, we need to get everyone vaccinated, that is powerful. If you are one of the very, very few people who have had an adverse event because of a vaccine, and you get out there and you encourage people to get vaccinated, your voice carries a certain amount of credibility that even yours and mine doesn't. And so I think unlikely messengers are the last thing. Obviously, the other thing I would say is primary care doctors, and I think it is still hard today, for primary care doctors to get access sometimes to vaccines for their patients. And we've done a great job of setting up mass vaccination sites. We've done a great job of pushing out the vaccine to CVS and Walgreens and so on. And that is important. But we have forgotten that a lot of people, number one, trust their primary care doctor more than other participants in the healthcare system. Number two, that's where they want to go to get vaccinated. They feel safe in that space.
I love your observation about we can't let vaccine hesitancy become part of people's identity. That's a really powerful observation. And frankly, Drew, that's not one I've heard before. It offers an insight into the way we had the mask wars and the culture wars, and nobody benefits from that. The idea that somehow something essential about yourself is at stake about whether you wear a mask or whether you take a vaccine, that becomes, you're absolutely right, a sort of created identity. It's not just an assumed identity. And we in the healthcare delivery system have to be really careful not to reaffirm or confirm or create that identity. And in some ways, some version of vaccines can be an expression of personal freedom.
Right.
Do it because you want to. I loved when Rochelle Walensky said early in her tenure, I don't wear a mask because Charlie Baker, the governor of Massachusetts, tells me to wear a mask. I wear a mask because I care about my family and I want to protect them. So coming up with ways to connect this to goals that people have and avoiding connecting it to some identity that people think they have that they need to defend as against assault is pretty interesting.
Yeah.
One more area I want to get into just before we're done, going back to that spotlight metaphor, the whole issue of disparities and health equity that were so laid bare by what happened with COVID. And one of the things that we've been talking a lot about from the foundation as we talk about confronting legacies of mistrust is something we call earned mistrust. The idea that people say, oh, I didn't do anything to lose your trust, so why are you mad at me? And the way in which institutions and individuals can acknowledge the lived experience of people who have been poorly served by the existing healthcare delivery system and acknowledge that, validate that, and commit to move on for that. Have you, as you've thought about this, what are your thoughts about how to connect to or be more successful in building trust with historically marginalized communities, poorly served communities, communities that have reason to be pretty unhappy with the healthcare delivery systems that have been there to serve them?
Yeah, It's a great question and such an important point. And, I think we talk so much about wanting to gain trust, and we don't talk enough about being trustworthy. And that is how you gain trust, right? It's the onus in some sense is on you to demonstrate trustworthiness, to demonstrate that you are looking out for the community's interest in a way that we haven't to date. And there's any number of examples that we can go through that have created a situation where people are understandably mistrustful of the healthcare establishment. I think that's so important with patient communities, but I think that's important within the medical profession as well, and within healthcare as well. One kind of anecdote early when as vaccines were being distributed, February, March, there were reports of extremely high levels, in my opinion, of vaccine hesitancy among healthcare workers. And you would see that the governor of Ohio said, 60% of nursing home staff are not taking the vaccine, and North Carolina said 50% of our nursing home staff aren't taking it. So I wanted to figure out, what is going on here. We healthcare workers are at the highest level of risk in some sense. We're exposing ourselves and others to the virus. And once you start hearing the stories of people who work in some of these settings, you understand why it is the case that when someone tells you, do this or do that, and they've never had your best interest in mind, why you feel hesitant to put something in your body. So I spoke to one, nursing home CNA, and she, African-American woman in her mid-30s, during the pandemic, she started working at 3 different nursing homes to cover, shifts, and was working 6 14-hour shifts a day, a week. And she, had asthma. She was really trying to avoid places with high levels of coronavirus spread. She would get to a nursing home facility. She would be told that there wasn't coronavirus in that facility, or residents didn't have it. She would not be given a N95. A week later, she would get a call that all these people ended up having coronavirus. She herself got it. She didn't get paid leave. She ended up having to go to her family for food and for rent support. And then, 2 weeks later, the nursing home's like, take this, that we think will help you. And so that is not an isolated story. That is something that happens every day to certain healthcare workers, but also to many patients. And so there's this kind of, political and healthcare system bias that has been going on for decades. And so I think overcoming that really takes another level of listening to people to try to engage in authentic dialogue. One of the things that I've been thinking about, in part because of the work that ABIM has been doing, is not just patients trusting doctors, but doctors trusting patients. And you want to feel like you are also trusted by your healthcare provider. I think long COVID is a great example of this. So, people reporting symptoms that are sometimes vague symptoms. They don't, there's not a lab test that you can, necessarily give for long COVID, but people are reporting things like brain fog, like fatigue, like, shortness of breath with ambulation, and so on. And many people are feeling dismissed. They are feeling like those concerns aren't being taken seriously. So part of this is really trusting the community, trusting your patients that what they're telling you is true, and doing your best to meet their needs.
I think it's so powerful when you describe that CNA and you say, somebody who's never demonstrated that they had your best interests at heart. It goes back to that third thing that you were talking about as a core of trust in healthcare institutions. Are you doing this for you, or are you doing this for me? And I think that's so powerful. And many of the listeners know that ABIM has gone through a period where the doctors, many of them, lost trust with ABIM and were frustrated with ABIM. And it was very interesting early on, as we were sort of trying to respond to that and manage that. One of the most successful things that we wound up doing was putting out data about how many residents in training would be affected by the immigration ban when the immigration ban was announced in January, February of 2017, that it was the first time that on social media people were saying, I love ABIM. And it was one of these things where we're not in the business of immigration, especially, and we're not in the business of, and this was just sort of data that we had, but for the community in which we were embedded, this was a huge, big deal. And our ability to speak to something that the community cared about, a lot of people, when they sit down to think about how do I build trust, they think about their core business and they say, well, we could do our business differently this way, or we could do our business differently that way. Maybe the most powerful insight is that the different way to do your business is ask your community, given that you have no reason to believe we've ever put your interests first, what would it look like if we did? The health systems are not in the Wi-Fi business or the network business, but what would happen if a health system in the community that it served during the pandemic made Wi-Fi available for kids who were trying to go to school? It's not doing healthcare better, but it's responding to a need that the community knows they have. I think in some ways, that's our most surprising learning, that the opportunity to build the strongest opportunities for building trust probably come outside the core business that we do, and more are related to better understanding the needs of the community we serve and thinking creatively about how we can help meet those needs.
Yeah, that's a fantastic point. Are there, I know you've been in touch with organizations across the country over the past few years. Are there things that, in a very practical sense that you've found or you've heard are the real secret sauce, that, interesting things? You mentioned the phonetic kind of spelling of a patient's name in the EMR. But what are the types of things that tangibly seem to increase trust in in a healthcare organization?
So great question. And we've cataloged those exemplars on the buildingtrust.org website, similar to the phonetic name spelling, an LGBTQ clinic, Unity Point, that focused on pronouns and to which really matter and which health records didn't necessarily carry, and they had to sort of think through a workflow of how do you do that. I think that kind of stuff is pretty powerful. We do hear a lot about transparency, and we also hear a lot about engagement of where in Parkland Hospital, the CEO of Parkland basically invited different departments in the organization to generate ideas around trust building practices and put forward ideas of things they had done. And there were various examples of meeting patients where they are that wouldn't necessarily have been where they would have started. So I think the most scalable idea is for a healthcare organization to ask itself in a serious way, if the thing we were trying to do was to get people to trust us, if that's what we were trying to do, what would we do? And you're right, the confidence is there, and you're not going to do it with a high infection rate, and transparency is there. You have to be honest with people, but we care more about you than we do about us. That's unexplored territory mostly. Yeah. Daniel, you joining us suggests that it's time to shift to the live Q&A portion.
It is the time to do that. You got that message. I'm glad. I wanted to, since I don't see any, I'm going to start off with, what does trust look like post-pandemic, and what does healthcare look like post-pandemic? Dhruv?
Yeah, I mean, it's a big question, and we could spend hours kind of talking through it and debating it. I think in some ways the pandemic has been such a kind of shock to the system, and it has changed everything. In other ways, it just revealed what was already there. And I think about things like a massive inequity at every level of society, but particularly within the healthcare system, meeting the needs of communities that have been traditionally left behind. I think there's going to be a lot more focus on that going forward. I think, telehealth is obviously something that, is here to stay in a really big way. And we'll have to see what that looks like going forward with reimbursement policy and usage and so on. But I think that is something that people have realized, that there's a lot of clinical situations that you have to see a patient in person. But there's a lot that you don't, and there's a lot of ways that you can check in. Phones are have been around forever, but there's a certain intimacy that comes from seeing someone and being able to communicate with them via video. And so I think a lot of that will stay. But not just video visits. I think things like remote patient monitoring will kind of continue and grow as people try to do more and more digitally going forward. And then I think, at least in some pockets, it will accelerate some level of payment reform. I think during the pandemic, people saw kind of the effects of having to shut down part of your business, whether it was elective procedures or something else, and some of the challenges that come with fee-for-service reimbursement. So there may be a greater appetite to move towards value-based payment arrangements and alternative payment models. And so on. We'll see what form that takes going forward, but I think at least people will start thinking more about that in the coming years.
Rich, anything to add?
Yeah, I make a couple of observations. As an employer, we're thinking a lot about bringing people back to the office, and we're hearing from people that they don't reliably want to come back to the office, and they feel like they've figured out how to work from home, and so mapping that to the question about what healthcare looks like. In many ways, patients had a lot more control of how and where they got care during the pandemic than they ever did before. Like before, the care model was, I got an office, it's on the 10th floor of a building in Center City. You want to see me? Fine, come see me. Parking, that's your problem. Getting here, that's your problem. And patients came to live in a world, and I'm building on your telemedicine theme there, Dhruv, but more in terms of the way in which patients had a lot more choices about how and where and from whom they were going to get care. And I think there will be a continuing level in the same way that the employees are saying, you think I'm coming back to the office 40 hours a week? Well, guess what? I'm not. I think patients are going to say, with respect to lots of things in healthcare, I don't understand why we need to do it that way. And I think that there will be, and I hope there will be, more pressure from patients to say, wait, I don't understand, you did it this way before and that worked better for me. What do you mean I have to go back to doing it the way you did it before? So I think there'll be some reinvention of care, a lot around technology, a lot around distributed care, a lot around teams, because I think patients in many ways were to some extent empowered by the pandemic.
So we got a question from Jackie Judd. So many physicians feel overburdened and burned out. Many view building trust just as another chore. What strategies do we need to think about to have physicians be truly open to this conversation about trust and the effort it will take to do that?
Rich, you want to start?
Sure. So I think that, first of all, clinicians, a lot of what's going on in burnout is when work feels like it doesn't have meaning and work feels like it doesn't have purpose. Certainly mastery and control are big pieces of burnout too. And I think that the diminution of control that many physicians feel in the work environments that they're experiencing is something that has been really hard. And I think the examples that Dhruv was giving of effective leadership and coming through the pandemic with more confidence in his clinical leadership, I think those are tools that leaders can use to allow frontline clinicians be in better touch with the meaning and purpose that drives their work. I think it's when your work feels meaningless when you feel like you're jumping through hoops because somebody put those hoops out there, that's a big driver of burnout. Of course, another big driver of burnout is massive clinical overload and lots of death and suffering all around you. And I think those kinds of experiences, they happen once a generation. They scar a generation of physicians. And I hope that we will be back to a world where clinicians have more hopes of being able to meet the needs of most of their patients. But I think being sure that physicians can connect with meaning and purpose, I think that's the most important thing people can do for burnout. Dhruv, what do you think?
Add to that, Drew?
I broadly agree with everything you said, Rich. I think it a little bit depends on how trust and building trust is presented to clinicians. If it feels like another checkbox that you have to check off in the EMR, or it's just a metric that you're trying to meet, I agree, it'll contribute to burnout, and people will think it's not central to what they're doing. But I think most physicians and clinicians feel that their patients trusting them is kind of core to professionalism. That is part of who we are as professionals. And so, when presented that way, I don't think people will view it as a chore, or I hope they wouldn't. And instead view it as kind of a part of who we are and what we do. And I think trying to get rid of some of the excesses that are around that take you away from patient care, that contribute to burnout in a more administrative burden type way, I think will allow people to kind of concentrate on building that relationship. And in some ways, I think of trust. On the one hand, it's something that we need to focus on and we need to think a lot more about. On the other hand, it's kind of a byproduct of doing really good by your patients, and it's part and parcel of that. So I think a little bit of it, like happiness, you don't get happy by aiming at happiness. You get happy by doing something that is fulfilling, and happiness is a byproduct. In the same way, I think of trust as like doing right by your patients, trying to meet their needs in the best possible way, creating structures around individual clinicians that allow them to engage in authentic relationships. Trust and trustworthiness emerge in those situations.